So then I will go to the specific consideration of medical management. Uh, so in general, the principle of medical management remains same. That we want 24 IOP control with minimal medication, no long-term trip, minimal local side effect, no systemic side effect, and a better adherence, better compliance. From here, this is a real case scenario. This patient I had seen when I was in Vellore doing my residency, and I have not exaggerated or not changed a single bit. 39-year-old female from Mumbai, where now I am, came for the second opinion for Dr. Avi Thomas, pain, redness, watering, photophobia, and I worked up this patient. 95, she was diagnosed anger closure when the pressure was 60. She underwent trabeculectomy. The fellow eye was not treated. Since symptom persisted, 98, she was diagnosed with right eye anger closure when the right eye pressure shot up, right eye trap. When the patient came, patient had no perimetry or no finding written on the whatever file she carried. And she was on this kind of medication. And why she came? Because she was advised retrap. We did diurnal. Dr. Ravi was very fond of diurnal. Patient had shallow bleb. Angles were 360-degree close, but the ostium was pattern. And what management? So we did perimetry. This is right eye perimetry is not correlating, but this is the first fit. This is the left eye. Again, the disc was reasonably healthy. And if you look the right eye, it remained same. Maybe a vascular event because pressure shot up more than 60, but the left eye was learning curve. She improved very well, which correlates with the disc. So from here, the question arises that what we should learn. This case teaches so many things, and the bottom line it teaches that we start from clinical examination that in Indian scenario, if you don't do gonioscopy in any scenario, but in Indian scenario more specific because we have lots and lots of anger closure, you are going to miss it. So we are treating the patient and not the symptom. Many other points, how to start the drugs, I don't want to discuss, but just I like to show this case because what you should not do, it teaches in one case everything, from your examination to the management. Now, so medical management, the principle is when to start treatment, what should be the first drug, when to add, what to substitute, which one, what is the maximum medical therapy, and the question what we are going to discuss is the difference between the anger closure and open angle glaucoma. Maximum medical therapy definition varies, but maximum number of concentration of drug that provides minimum number of drugs which provide maximum lowering IOP. It looks contradictory, but it's logically that you have to understand that you want to give the as minimal number of drugs possible, preferably in combination, which reduces maximum. So initially 3 drugs were written because the combinations were only in 2 bottle 3 drugs. Now we have prostaglandin, timolol, and CI inhibitors and beta alpha 2 agonists, so we can give 2 bottles 4 drugs. So, but it has to be individual patients. So how much your patient can tolerate without affecting his quality of life and work, that you have to see. So in anger closure glaucoma, iridotomy is the bottom line. Once the patient has anger closure or glaucoma, we are not talking about occludable angle PACS, which Bhaskar has already elaborated in detail. Here, when I talk about this, you have to remember lots and lots of patients come for the second opinion to glaucoma specialist, and if you look the Chennai glaucoma survey, they found that significant number of patients were diagnosed open angle glaucoma which actually had anger closure. And anger closure can cause more rapid blindness compared to open angle glaucoma. So all glaucoma required, all glaucoma, ideally every patient who comes in OPD, but at least when you suspect glaucoma, they have to have gonioscopy. Now the one iridotomy is there any difference between the medical, surgical part Thomas will take care in open angle and anger closure. So there are some RCTs, some meta-analysis, and I will just briefly cover it. So the RCT says that IOP reducing efficacy of latanoprost was slightly superior to timolol or marginally inferior to the travoprost and bimetoprost. So basically, prostaglandin reduces IOP as much as beta blocker or little more than beta blocker. Conjunctival hyperemia, again it is same as open angle, that latanoprost causes less to timolol and lesser than travoprost and bimetoprost. So the bimetoprost causes more hyperemia, compared to latanoprost. So, but all prostaglandins, so initially was that if the angle is closed, the IOP reducing ability of prostaglandin would be less, but this all the RCTs and meta-analysis show that are at least same or more than beta blocker. Then this is a meta-analysis. The difference of absolute IOP reduction between prostaglandin and timolol varied from 0.4 to 1.6 at diagonal curve, 1 millimeter to 2.3 millimeter at peak, and 1.3 to 2.4 millimeter at trough. So it reduces more than timolol. So the authors concluded that prostaglandin provides significant IOP lowering efficacy in eyes with angle closure glaucoma, and all prostaglandins were as effective timolol or little more than timolol. So from then, this is how, and the earlier the long back T-Nong was the first who did the RCT, and they found that the prostaglandin analog even in totally closed angle is comparable to the prostaglandin analog. So but as the angle sinus of number of clock hour increases, the IOP reduction ability decreases little bit, not significantly, but little bit. So if the ideally angle closure glaucoma, prostaglandin can be used as a first line. Of course, beta blocker is always there. But here the patient on pilocarpine, you have to remember that prostaglandin analog IOP reduction ability add-on effect is only marginal, 1 to 1.5 millimeter mercury. So if the patient is on pilocarpine, then you should think of adding other medication rather than prostaglandin. Or if you want prostaglandin, then stop pilocarpine. Anyway, I don't use pilocarpine in my practice very much. This is article we had published 2 years back, that the clinical implication of recent RCTs on angle closure disease, and this is where our remarks that medical management is similar if the LPI is patent. Prostaglandin analog is first line. However, if cost is an issue and patient does not have any systemic contraindication, here you remember systemic contraindication, beta blocker has lots of systemic contraindication. So if not there, then topical beta blocker is a good alternative. Other eye, pilocarpine in play to iris. So when we did the literature review, there is no RCT or meta-analysis for the effect of pilocarpine in play to iris syndrome. Iridotomy has to be done. After that, the literature suggests that PIs, we know that anterior located ciliary processes support the peripheral iris. We also know pilocarpine produces iris thinning and is effective method of opening the angle and can be considered once the LPI is patent. So we are using it pilocarpine. When pilocarpine 1% was available, I used to use much more. Post iridotomy 2% I don't like because it causes more pupillary constriction, and later on when the patient needs cataract surgery, surgeries become more difficult. So I am not very fond of 2%, but yeah, you can use. So from then I'll just give the broader outline. Proper baseline examination is must. Target IOP calculation you have to do, and this is just general for POIG and PACG. Is a dynamic phenomena, keep changing as the disease status changes. Corneal thickness should be integrated, but you should not use the nomogram to correct the IOP. Ideal word, even in angle closure glaucoma, I would think prostaglandin analog is my first line unless they are absolute contraindicated. Follow up, there are all the issues you have to look into, just like POIG. You have to remember in angle closure, even in open angle glaucoma, we have seen lots of time open angle glaucoma patient progresses to angle closure as the age increases. So gonioscopy is must on a regular interval. The EGS guideline says every 3 years. I would say at least once a year in Indian scenario. And if Bhaskar Thomas has any other idea, they can later on talk about it. But I would say one, detecting progression is important earlier. Progression of synechiae in angle closure disease also is a sign of progression.